Okay. Hello, everyone. We have a fully packed agenda, so let's start on time. Thanks for joining the FCC Task Force 5th webinar series on mental health support for NICU families. Next slide, Caroline. You all heard us talk before, and Colby and I are co-chairs for this task force, and I'm Malati Balasundaram, Stanford faculty, and Colby Day is a faculty from the University of Rochester. And Carolyn Tony Nolan is the task force program manager who keeps us organized and makes all of our ideas happen. Next slide, Carolyn. We are fortunate to have a few partners to help us promote this critical work. We want to acknowledge their support in this slide. Next slide. And this slide shows today's agenda. We will start with the brief task force update, and we will then have 3 sessions to discuss why and how to provide mental support to NICU families. We will have a first question and answer panel discussion after Dr. Mike Hynan and Necole McRae's talk. And the second question and answer panel discussion after the presentation on local and national parental support. Please post your questions on the chat. And next slide. So this is one of my favorite slides, and we are lucky to have 17 family partners in our executive council to guide us in this initiative. Thank you all for your commitment. Next slide. This slide shows our healthcare providers and the executive council. This includes our small group leaders and QI mentors and nursing leaders and the planning committee mentors. And thank you everyone for your commitment in this task force initiative. Next slide. So I formed this task force last November this time by recruiting a passionate providers and started with the 25 members at the time. And we have expanded to over 330 plus members globally in 1 year. Together, we really can make a difference. And this slide shows our Padlet screenshot and with all the resources and webinar recording. And so you can share this with your unit staff, and you can just scan the QR code. And so it takes you directly to the Padlet resources. And there is a section called Padlet question and answer session. So you can post the question so everybody can chime in of the answers. And so please check it out, this Padlet website. And if you have any suggestions, let us know. And so you're going to see the poll popping up on your Zoom window. Please take a few minutes to answer those 2 questions. So we will get to that answers before the second and third presentation. I'm just going to answer mine here. And okay, thank you. And with that, and next slide, Carolyn. I have the pleasure of introducing today's speakers. And so first we have Dr. Mike Hynan, the father of Chris Leslie Hynan, who was born 10 weeks premature in 1980 and spent 42 days in NICU. Mike wrote The Pain of Premature Parents, a Psychological Guide for Coping in 1987. He has published on emotional distress, primarily post-traumatic stress among high-risk parents, and developed a questionnaire called Perinatal Post-Traumatic Stress Disorder Questionnaire, PPQ, which has been used both clinically and in many research studies. He is currently an emeritus member of the Board of Directors of the National Perinatal Association and a member of the NICU Parent Network. And next, we have Necole McRae, a veteran NICU parent and one of our task force family partners. She is the vice president of a Globe Preemie organization and executive director of Free to Read Education Recovery Services and a lead family partner in the CPQCC NeoBrain Collaborative. We are honored to have her on our family partner executive council. She will share her experience of the importance of mental health support for NICU families. Thank you to Necole for joining, and please take it away, Necole. You're still on mute, Necole.
Can you hear me? Hi, good morning, everyone. My name is Necole McRae. As I was scrolling, I saw some familiar faces. So to everyone that knows me and I know them, hello. And everyone else, it's nice to see you, virtually meet you. Um, so I am the parent of a 25-week, 1 pound, 14 ounce little girl named Amari. And these two photos right here, if you've ever heard me speak anywhere, these two photos no one has ever really seen. Um, these are the only two photos that I have and that were ever taken of her father in the NICU. And it's not because he did not come to the NICU. It was because there was no mental health support services. So first, let me start off with this because if I don't say this, then you're not going to understand the end of the story and what it leads to. Um, a lot of you have heard pieces of my story, and I can guarantee you that you have never heard this piece. Um, I am the survivor of child sexual abuse. I put my abuser in prison, and at 19, I was ordered to 24 months of court ordered therapy. It was ordered. It wasn't like I wanted to do it. So in the beginning, I didn't take it seriously. I didn't see the need because I was so angry that I was forced to be there. Um, at some point, I don't know, maybe the 8 month mark, I started to realize it was needed. So I went ahead and did the steps that I needed to do to start to heal. Fast forward to January of 2009. I am married. I have two bonus daughters, and I am on the verge of a divorce. We've agreed to divorce, and we are living in California. But he wanted to take him and the girls back to North Carolina, and he was going to drive. And I just could not, within me, say, okay, I've been a mother to these children, for 7 years, and just let him get on the road with two little girls and, drive across the country in the winter. So I left most of my things here in California at my mother's house. I packed up a month's worth of stuff to go with me. And I got on the road and I helped him take the girls back to North Carolina. And in doing that, um, we still agreed to the divorce, and we had 90 days to get them settled, to get the girls in school, and to let them know that we were divorcing. In the midst of that, I find out I'm pregnant. So fast forward to August of 2009, and um, I'm still on divorce track. Like, just because we have a kid, I does not mean that I'm gonna stay, and it's not gonna be a healthy relationship. So I'm gonna leave. And I was still there, pregnant and all. I just verbally never said it, but I was there. So she's born August 8th, and it's a whirlwind of emotions, good and bad. But first time in the NICU, and I don't really know what to expect in the NICU, so I just roll with the punches. Um, at some point, I decided to stay. I just felt like I had to give my daughter the opportunity to grow up in a family for at least a little while that had two parents. And so I made the decision to stay, and we rolled with the punches and lived in our NICU bubble. Because as long as we were in the NICU bubble, we didn't have to deal with life. While we were in the NICU in our little bubble, there were things that happened with my daughter's care. But it never dawned on me that my husband was not coming to the NICU. Um, he worked, so I understand that he was in and out when he could. I did not know that it was a never. I didn't know that he was only coming to the hospital when I was there because I wasn't checking up on him. I wasn't asking the staff, like, oh, did her dad come? Like, I didn't feel like there was a need to do that. Like, you're her dad, you're gonna come to the NICU. It's all good. Um, so 3 hours before we were to pick up his grandmother to see our daughter in the NICU, she died. She was the only person that I had in North Carolina that was a friend that I could talk to, and she was her great grandmother. So it was good to have that grandparent experience there because I was missing my own grandmother in California. So I left the NICU because we had to go back home. I had to stay there for a while and do, funeral services and everything. And during that time, the social worker came to my daughter's room. I wasn't there, hadn't been there in 3, 4 days because we were 4 hours away dealing with family stuff. So on the way back to the NICU, we stopped pick up mail, and there's like 4 packages about an inch thick, and it's all Social Security. And I have no clue what this is. So I open it all as we're driving back to the NICU, and my daughter's name is on everything. She has a Social Security number now, and I'd never seen it before. And it's just all this medical terminology and paperwork. And the only people I trusted at that time were the house manager at the Ronald McDonald House and one of her night nurses, Misty. So I took all this paperwork to the NICU and I showed it to Misty and I said, I give you permission to look at and read all of it. I just need help. I don't know who to go to, who to talk to. What do I do? And she says, talk to the social worker. Have a conversation with the social worker. And she tells me in the state of North Carolina, when you have a child that's born into the NICU, we automatically put you on your child on social security. Okay, thanks. Didn't know that. What do I do now? She directs me on how to fill out the paperwork and everything like that. And in all of this, I hand 2 of the stacks to my husband, and I kept 2. And he looked at me and was like, "What do you want me to do with this?" I don't know either. We're both in the same boat. Like, you take half. And he says, "I'm gonna go see the baby," and leaves me there with all the paperwork. All right, at least you're going to see the baby. So I'm not going to complain. I fill out all the paperwork, get done with it. And as the social worker is talking to me, she hands me her own stack of paperwork. And in it, she's telling me what each pamphlet is for. And so she hands me one and says, this is, if you need to talk to anybody, mental health services is there. The numbers are provided in the pamphlet. Okay, thanks. Just as sure as I'm sitting here talking to you right now, I can guarantee you that pamphlet ended up in the trash as soon as I got home. Like, it just did. I was inundated with so much that anything outside of my happy NICU bubble and looking at my daughter in her plastic case was too much to deal with. And no one said anything. And then when they did ask me, "Are you okay?" It was, "I'm fine, I'm fine, I'm fine." Because I don't trust you enough to tell you what's really wrong with me. And if I tell you what's really wrong with me, how do I know that you're not going to take my kid? So no, I'm fine. That works for me. Um, the first day that I went in to go see my daughter, they directed me to this NICU pod and this cute baby. And I was like, oh, I don't think that's my baby. And all of a sudden, down the hall, I hear this woman screaming. She is livid. "This is not my child. You lost my baby. Where's my baby?" And I walk, and my husband and I and her husband, we walk and we're crossing one another. And this woman looks so much like me that it's scary. And she looks at me and she goes, and I do the same thing. And then I realize, oh, they thought I was her. They thought she was me. So they took us to the wrong babies. So every time I saw that woman after that, she had this look of, that was you, right? Because you were the one that was sitting at my baby's bedside. And I didn't have that look towards her because I understood it was just a mix up. But for her, it was so much more traumatic that she couldn't even have a conversation with me. So one day I started one with her. And as I'm starting this conversation, I don't even think it was the social worker. I don't know who she was. I don't know what her title was, but she pulls all of the incoming NICU parents in this room. And she talks to us, she says, "Look around." She goes, "All the couples that you see in here," and it was about 14 couples in that room. She says, "All the couples that you see in here," and she goes, "by the time your kid is 5 years old, only like 5 of you will still be together." And all of us took offense to it. We're like, you don't know us. But 5 years down the line, there were only 4 that made it, and I was not one of them. So I ended up going through with the divorce. But we took that opportunity in that moment, as we directed our anger towards that woman for saying that to us, to kind of forge a friendship, and we forged bonds. And it was not the mental health professionals in the hospital. It wasn't the doctors. It wasn't the nurses. It wasn't anybody other than the parents that I made friends with in the NICU that I had to talk to. And so we created our own parent support group because we were all going through the same thing, but our children were at different levels. So we had, 2 cardiac babies, we had 2 gastro babies, we had just 2, preterm babies who were fine. We had, the neck babies. My baby was the neck baby, so we had, different levels, but we all were going through the same thing at the same time, and we had nobody to talk to. So we talked to one another. It was not until the FCC task force topic list came out that I was like really focused on, oh my gosh, there was no mental health professionals. I didn't have anybody to talk to. There was nobody that even suggested that I talk to somebody. Like, why? And so, and then I started thinking about all my time in the NICU and how much time my ex-husband did not spend in the NICU. And so while we don't talk now, I had called him and I asked him, I said, why? Why did you not go to the NICU? Why did you stay away? Why did you only use, the other men in our group as a support? Why did you only talk to them? And he said, because it was just women everywhere, women all around. I'm supposed to bare my soul to a woman, and I got a wife that I can't even bare my soul to. How am I supposed to do that in this situation? I didn't want to talk to another woman. I wanted to talk to a man, and all the men who were around were doctors, and they didn't have time to talk to us anyways. So what was I supposed to do? I hung out with the men who were there, who were going through the same thing, and we didn't always have to talk because we already knew what we were going through, and we just did not want to talk about it. And I said, well, how do you feel now? And he said, I wish I would have had somebody to talk to, because I'm still dealing with the feelings of guilt of not going to the NICU when I had the opportunity to go. So it is so imperative. It is so important. As soon as you are entered into the NICU, to have somebody who is identified as a mental health professional, as a parent support counselor, as somebody that parent can talk to, because they're not going to want to talk to anybody, but they're going to need to talk to somebody. And you need somebody there that's going to recognize that they're not going to want to talk to somebody, but they need to talk to somebody. So thank you. Mike.
Thank you, Necole. I'm going to go off my script here. And I would ask that changing the slides, if you would skip over all of my data slides and maybe just show that last figure slide. So if you'd skip 4 slides, what you're going to see in those slides is something that I hope that most people in the audience are already familiar with, that if you have a NICU baby, you're going to be having elevated levels of depression, post-traumatic stress from national averages. That's great. You can stop there. Going off script from Necole, 2 things struck me from what you were saying that I want to talk about. Paperwork and trust. So I already saw, I think that Keira put up that social workers are, overloaded with paperwork and too many other things to do. National Association of Perinatal Social Workers has standards that there should be a social worker for every 20 NICU beds. And I'll let those of you in the audience figure out whether your unit has kept up to those standards. In 2015, National Perinatal Association made recommendations that there should also be a psychologist for every 20 babies in the NICU. And currently there are, by my last count, only about 18% of the NICUs in the United States have a psychologist, and most of them are part-time. So I think we need more people in the NICU who have mental health credentials, who will be able to develop trusting relationships with parents. I always liked the model of what I called the Zena Steinberg method of being a NICU psychologist. Zena was one of the first NICU psychologists, and she would arrive on the unit. She was part-time, but she spent her time going through the unit and introducing herself to every family by saying, "My name is Zena Steinberg, and I'm a psychologist on the NICU, and I talk with all parents. And I'd like to see how you're doing, and can you please tell me about your baby?" So she was beginning to engender a relationship with that parent, mother or father, and to learn something about them. And trusting relationships for me are central to mental health in all ways in the NICU. For this complicated graph that you're looking at, the only thing I really want to impress upon people is that looking at overall averages from research studies can be misleading because the averages obscure individual differences. And so in the NICU, we can expect that parents will mostly fall into one of those four trajectories. Resilience is the best adaptation, and resilient parents will still feel some mild to moderate distress, but mainly they'll be able to still live their lives. Up at the top is the unfortunate chronic trajectory, for which about 25 to 30% of parents will fall into. Those parents should be receiving care from a NICU mental health professional in the NICU, ideally, and not referred out. The resilient group is also 25 to 30%, and in between are delayed and recovered. My wife and I were both in delayed and recovered. And my wife and I both went into psychotherapy during the first year after our son's life for our NICU experience. But let me just say that we need more NICU psychologists, both for parent support and also for staff support. Staff burnout is atrocious. Figures of replacing nurses from a national survey in 2021 was about $48,000 to replace a nurse. Dr. Joaquin Prophet, I heard in a webinar a while ago, say that at Stanford, it cost over $1 million to replace a physician. This should be part of the argument brought to hospital management for more mental health professionals. But as I conclude things, I really want to talk about parent-to-parent support as also being mental health support. It's very fitting that the speakers following Necole and I are going to be talking about parent-to-parent support, both at a local level and at a national level. I work frequently with the group of NICU psychologists in the United States called the National Network of NICU Psychologists. And my psychologist friends are chagrined when I say to them, as I often have, if I ever had to make a choice between having a psychologist in the NICU or parent-to-parent support in the NICU, I would choose parent-to-parent support, right? Parent-to-parent support is universal, and it is also mental health support. And kind of finally, in conclusion, to, I hope, bolster my point a little bit, I've been impressed over the last year of reading a book called Breathe, Baby, Breathe by Dr. Annie Janvier, who is a neonatologist from Montreal and the mother of a preemie. Dr. Janvier describes her life before and after giving birth to Violet at 24 weeks. The book is remarkable for many reasons. I cried frequently reading it. One thing that jumps out is the raw language that Dr. Janvier uses to describe her feelings. Her descriptions reveal many of the emotions of NICU parents that NICU staff never get to see or hear. And during our preparation for this part of the presentation today, Necole and I shared a common understanding of the raw language and the importance of people being able to hear it, because most people who work in NICUs do not see or hear the things that Dr. Janvier describes going on in her life. Secondly, Dr. Janvier also makes it clear that when she wanted support, she did not choose the NICU staff. She wanted to talk with former NICU parents that she had cared for. So I think that Breathe Baby Breathe is a great book for NICU parents, and it also should be required reading for anybody thinking about going into pediatrics. And so that's the last of what I had prepared to say, so we can move on. Thank you.
Thank you. Thank you, Mike and Necole. Colby, it's
Yep. So we have a little over 10 minutes that we can spend now on questions for Necole and Dr. Hynan. I do want to echo all of the thanks that you guys have received in the chat for sharing your stories and your expertise on this. I didn't see direct questions yet in the chat, so please feel free to put those in. But one thing I did want to bring up, something that really stuck out to me, at least, Necole, and what you had said, is you made the statement, if I tell you anything, how do I know you won't take my kid away? And I feel like that was a really powerful statement in what you said. And it made me wonder how much of a barrier that is, that fear of being vulnerable with either mental health professionals or social workers who I appreciate our chat, clarifying that they are mental health professionals in our units, or even our buddy system, how much that might be hindering communication from families and how we might be able to get past that.
That's a hard one. I am an educated, I'm educated. I live a fairly, peaceful life. I don't live beyond my means. There was nothing, I'm not in any sort of trouble. There is no reason why I should have been afraid to say anything. But when I looked at her and I thought about the color of my skin, the people who were around me, and the history of things that happen to people when they make statements that are truthful statements for their feelings in the moment. And I thought about, they made those statements because they felt safe enough that a person would understand what they were saying and what they were feeling, not because they wanted any kind of repercussions, negative repercussions that came against that. And I felt like in those moments that, nope, this is not safe. I don't know you, you don't know me. You're a person who comes around and asks me to sign a piece of paper every couple of days, and then you go on about your business. I'm not going to tell you anything personal about me because I don't know you. And I don't trust that if I tell you I am feeling like I want to hurt myself right now, I'm not going to hurt myself, but I feel like that because I feel helpless. How do I know that you're not going to say, oh, that's a red flag, let's take her kid? I didn't know that because I don't trust you. I don't see you enough to trust you. I don't see you around my kid enough to trust you. So I'm not going to tell you anything. So honestly, that's a hard question to answer. How do you get around that? Is really individually. There is no big blanket answer to fix that. It's individually, because you have to spend time with the person that you're asking for this vulnerability from. And if you can't do that, then you shouldn't expect to get it.
No, I appreciate that. I think it rings true that there's not going to be one overall answer for it, but certainly I think it's something we need to keep in mind, that it may be something that's keeping parents from being able to express themselves and ask for the help that they need if they really don't have that trust. And we've kind of hit on that a lot in several of these webinars, that building trust with families is a huge area of need in the NICU. I saw there was a question specifically for Dr. Hynan in here as well about spouse and partner mental health in the NICU. I don't know if you have any comments on that topic.
One thing that I can certainly say, both from personal experience and from the data, is that when my son was in the NICU, I think I was in tandem with my wife with respect to feelings of depression. All right, when she was having a worse day, I was having a worse day. When she was having a better day, I would be having a better day. And maybe it was, you know, vice versa. I'm not really sure about the direction of causation. But the data are very clear with respect to depression in NICU mothers and fathers, that if one of the partners is depressed, then it really jumps up the likelihood that the other partner is going to be depressed. So in some of that data that was not shown, basically, you know, maternal depression rates in the median are between 30 and 40% in the NICU. And if you add a partner being depressed on top of that, then I think you're going to over 50 to 60%, just as a guess. So it's another thing to look out for.
And I know there was a request to, if you could repeat the organizations that had made the recommendation for 1 psychologist per 20 beds and 1 social worker per 20 beds, if I remember correctly.
The social work recommendation can be found on the NAPSW website, so National Association for Neonatal Social Workers. The psychologist recommendation, which was in addition to the social worker, not to replace social workers, but in addition to the social workers, came from a 2015 special issue of Journal of Perinatology. It was the December issue. And if you go to Journal of Perinatology, that whole issue is online. It can also be viewed at nationalperinatal.org. But within the article in that issue on mental health professionals in the NICU, there were the recommendations that were made that there also should be a psychologist for every 20 beds. And obviously, there are only a few NICUs that I know of in the United States that have more than 1 psychologist at the time.
Yes, I think we feel lucky if we have access to those services at all. For most of us, certainly not going to fall into the 1 per 20. Necole, there was a question about whether you were offered chaplain services and whether this would have been something that would have been helpful, or if you would have been receptive to that offer during your NICU stay.
I was offered chaplain services through a pamphlet. So it ended up where all the other pamphlets ended up. Had I verbally been offered chaplain services, yes, I think I would have been very receptive to it. I have a faith and I have a belief, and, you know, I go to church. And so I think that it would have been a comfort to me that would have been familiar. So I would have done it. But no, it was not, it was offered to me in a pamphlet.
That's another point I had written down, actually, was I enjoyed your comment about the pamphlet going straight into the trash during your talk as well. And we do that a lot in the NICUs. We provide these booklets normally, right, or folders that have pamphlet after pamphlet of really great information that people have spent a lot of time putting together. And I would imagine have the best of intentions on providing resources for families. This is for both Necole and Dr. Hynan. Do you feel like there is one way of providing that type of information that is best? Do you think that families should be given it in multiple different formats? Necole, I know you mentioned, you know, in-person offering. What do you think is the best way to get those resources, the information about it, to families?
So I am a person who needed it offered in multiple ways. You handed me a pamphlet, and in the moment that you handed me the pamphlet, I was inundated with like 500 pieces of paper. So if I didn't have to fill out that piece of paper, then it went to the trash. Had you offered me the pamphlet at another time, I might have been more receptive to it. So I think that offering those sort of services multiple ways would have helped. Had there been, like, I don't know what you guys call them, but in the rooms, you guys have the board with all the vitals and the names. Okay, so everyone who goes into a room, like, you look at that board, but it's so commonplace after being in the hospital for so long to just look at it. It's kind of like, oh yeah, I know that it's up there, the information's there, right? You don't really pay attention to it until it's new information. And so had it been posted on that board that I paid attention to every day, I would have recognized it and maybe wrote it down, or I would have asked a question about it and, like, why is this number up there? What is that too? Which would have prompted me to ask for the help. But again, if you don't know to ask for the help, you don't know you need help. So what do? Other than continue to have pamphlets thrown at you and continue to have doctors and nurses and healthcare professionals say, hey, you should try this, because I also understand there's a line that you guys can't cross. Like, you guys can't just say, hey, I think you should go to therapy. You guys can't do that. So there's a line that you can't cross. But when you're in the midst of your trauma, sometimes you need somebody to step on the line so you can click back into, like, back outside of that NICU bubble and realize, like, real life is still happening outside of here.
Dr. Hynan, any closing remarks before we go to our next speakers?
Yes, step on that line. Don't be afraid to cross the line. Just as also in his aside with getting handed pieces of paper, I didn't talk any bit about screening in the NICU, but I think the worst way to do screening is just to hand a questionnaire and, say, fill this out and I'll be back in a half hour. That the trusting relationship with somebody, whether it's a nurse, social worker, psychologist, develop that trusting relationship. And that can be the avenue for a lot of informal and formal help to happen.
Thank you both so much for your insight. We really appreciate it.
Thank you.
Thank you, Necole.
Thank you again to Necole and Dr. Hynan for sharing your expertise. We can take a look at our poll result. Caroline, you can share our result. Okay, and so the first question is, do you have any parent or pair buddy program? So 49% they do have, and 44% they said they don't have one. You're in the right place. We are going to talk about this local and national support and the next session. And if you have a buddy program, do you have any support from the other organization? So it seems like 41% they don't have any support. They just run by their own institution, and 17% reach out to the national organization, and same 17% they do go to the local and regional NICU organization group. That's great. So it's interesting segue to our next talk. So our next speakers will share about, next slide, share about the parents at the local NICU level. Dr. Dharshi Sivakumar is a clinical professor at Stanford University and medical director at El Camino Health, a community level 3 NICU. She is my mentor and colleague and passionate about providing emotional support to families. And she is instrumental in initiating the buddy program in our NICU. She will join with Michelle Ranch to share their work. Michelle Ranch is a NICU nurse and NICU parent to 3 preemie girls. She works at El Camino Health NICU, where she runs monthly parent exchange hours. She's also the chair of the CPQCC Family Advisory Council and working to build a statewide family advisory council. Both will share ways to support NICU parents locally. And followed by Keira, Sorrells and Meegan, Snyder, about sharing their power of peer support at the national level. And as a founder and executive director of the NICU Parent Network, Keira has been leading the movement to elevate the NICU parent leader as a professional in maternal infant health. After giving birth to triplets at just 25 weeks, 5 days gestation, and losing one of her daughters at 14 months old, Keira was propelled into maternal infant health out of an unshakable desire to ensure no parent experiences the trauma of preterm birth or loss on their own. She is the lead family partner in our task force and an actively engaged executive council member and a small group leader. And she will join with Meegan Snyder. Meegan is the director of a preemie parent mentor program with Grams Foundation and also a family partner in the FCC task force. She is originally from New Zealand. Meegan is a certified trauma-informed professional and has degrees in hospitality management and business from Wintec and Hamilton, New Zealand. After the birth of her daughter at 28 weeks, Meegan wanted to help other preemie parents, so she joined Grams Foundation, first as a volunteer mentor, then in 2018 became the director of the mentor program. She recruits, trains, and matches volunteer mentors with other preemie parents so that no parent has to go through the journey of prematurity alone. With that, I will give the virtual platform to Dharshi Sivakumar.
Thank you, Malati, and thank you for that amazing presentation on the importance of mental health support in the NICU. I cannot speak anything more than what you said. I think that is a crucial part of our NICU support. Now, Michelle and I will discuss how we healthcare providers in the NICU can support the families to reduce the stress and trauma during their infant stay. Next slide, please. The question comes, why do we need to support the families? Over the past few decades, the NICU philosophy has actually changed, and how we care for our infants have changed. Introduction of family-centered care and family-integrated care has allowed the parents to spend more time in the NICU and actually witnessing the ups and downs of their loved one's journey. That is actually going to hurt them more than just going through the preterm delivery. Especially for the mothers, the guilt of delivering a preterm infant is difficult to accept, and they blame themselves for all the suffering the infant is going through. The guilt, the anxiety, and sadness of losing the normal pregnancy fuels the trauma and stress. Over time, this will lead to postpartum anxiety, which happens at the time of discharge, and post-traumatic stress disorder after they leave the NICU. So we support families to reduce as much as we can. And also, as the previous speaker said, identify the family who needs more support with mental health support. Next slide, please. Reviewing the literature in family support, I could recognize a few common positive supportive methods for the families during their NICU stay. Meeting other parents in the unit, regular social and informative group sessions, because sometimes we only do the informative group session. The social sessions are also important, where they come together and work together to do something for their own infants, which is very nice for the families. Online groups, nowadays everybody is going for online groups, but even having NICU-specific online groups. Peer buddy program, we heard enough today, but I cannot say more than that, because I have been doing peer buddy program for the last 20 years, unofficially. Because I did the high-risk infant follow-up where I met the families, I heard their stories. And that's what made me so passionate about peer buddy program or parent support. So unofficially I was doing, but 2019, we decided to do officially. That was the start of our parent buddy program. Psychosocial support and participating in their care of their infants, little things that we can allow them to do. Holding babies, even if they are on the ventilators, pumping at the bedside, giving support, infant massage program, positioning babies, touching babies, giving them a chart to say, this is the developmental care program you want to do for your baby, even dressing their babies. All this actually a therapy for the family. Next slide, please. Now we are going to talk about a little bit about understanding how to set up these programs. So as Malati said, I work both at Stanford as well as at El Camino, which is a community level 3 NICU. So in my opinion, we try to do this family-centered care as well as parent buddy program in both institutions. And I'm going to say, what are the difficulties we faced in that process? When you take a larger academic center unit or children's hospital, the hospital administration is happy to support this. Patient experience will love to help you. And they will have funds available for you. And you also will have trainees who wants to do these kinds of projects. But the most difficult part that we felt was that the culture in the unit. It is so difficult to change. It's like they only worry and care about acute care, not about what happens to the families, what is beyond NICU, nobody talks about. Every time parents come in, they are giving the list of all the things happen, but they ever say, how can I support you? And then comes the other subspecialty providers. They really don't think about anything. They just want to do the work and go out. And in the academic centers, we do transport babies in. So most families live far away. So they are only coming once or twice a week, maybe on the weekends. How are we going to support those families during that time? Now, if you take the smaller unit, like what we have at El Camino, the hospital administration is unaware of any of these that's going on in the NICU because they only worry about adult patients. We are in the small world. That's how I call myself. We are in the small world. And when we are in there, we need to go to them. So you need somebody who knows the problem and reach out to hospital administration. Patient experience, another story, because they only look at the satisfaction score for the whole MCH. NICU is not separately looked at. So you really have to say, can I have the Prescani scores from the NICU? So I can really show you where the sufferings are, what the families are saying. So these are quite important to start off with, and then finding the funds. And the funds are going to come from the hospital administration and patient experience. Why we need funds? Because we do have staff who are willing to support families in the smaller NICUs. They will change the culture and do what you tell them to do. But you need some time for them to spend, and that needs to be funded. So that is quite important. So what we actually did is we got the Prescani scores, we went to them, told the patient experience, we are going to change. This is your incentive to change. And then we secure some funds. And then we went to the staff and said, let's form the group. Next slide, please. So in the process of preparing for this presentation, I sort of jumped into these great articles. And if you are trying to set up, we should post this into our resource session in the website. And these are great. And especially the 2022 article actually looked at 35 different studies done, how to support families in the NICU. And they have tabulated all different things. And it's a great resource for you to have. Next slide, please. So as I said to our hospital, our journey, we went to the hospital patient experience leadership and said we need assistance to set up the parent buddy program. So as a help, we were able to get a consultant who is an expert in doing National Parent Buddy program, and also a trauma therapist, actually, she was, from the hospital maternal outreach mood services. at El Camino Hospital. So that took us to do the work on really looking at how we are going to set up the program. Then, of course, you need the staff support, the physician, nurses, administrators, and also veteran parents joined us, because we did have this NICU reunion where we were just setting up a lot of our veteran parents to be part of our group. And we also formed the family advisory board, who also were joining the veteran parents. So we were able to do that. So as a start, we set up monthly meetings. I'm going to say it went on for about 6 months to set up all the relevant forms, the training process, matching process, and how we are going to evaluate our program. You also need a care coordinator. And one of the things I sort of learned recently is we have one of our nurse educators as a care coordinator, but that is too much. And I think we should get a parent as a care coordinator who can actually manage the parents and support the families in the NICU. Next slide, please. So this is, again, these resources will be available for you to look at it, but you can see that we come up with a policy and a program development, how we want to set up before we started the program. Next slide, please. And this is the team, and you can see the 2 parents as well as the physician, our nurse educator as a care coordinator. And in different shifts, we got nurses to participate so we can make champions in each shift. Next slide, please. So first and foremost, we did a parent buddy applicant questionnaire, and both Malati and I interviewed the families who wanted to become parent buddy. And we had one requirement: at least the child should be 1.5 to 2 years old, because we felt that it is important for them to have some time with their baby before coming back into NICU. And after the interview process, we assessed for their psychologically whether they are ready to do that. And once we were confirming that, we put them in the pile or pool to have the mentor session. Next slide, please. And this is actually showing you the process, how we really did the work on a parent buddy program. So first identifying the families, interviewed, then we go through the training, and then they are in the pool of mentors. Now then we had to go and identify the parents who really need that support. And generally we find that the parents in the first week or 2, they are too overwhelmed. They don't want a buddy at that point. But once they get used to it, then they will say, okay, I would love to have a buddy. So then trying to match the mentor and mentee, that is also important. And we will use the gestational age, even ethnicity, race, all that played an important role. So that way they can actually become it's like a friendship rather than parent buddy, just supporting at that point. And some of our families are supporting many years. I know one parent I started 6 years ago, they are still together, working together. Next slide, please. So again, the request form and all the other form, we can just go through the next few slides for the time reason. It is just the forms. Next slide, please. Okay, so this is the buddy matching process I just talked about. And now our coordinator actually works, and we sit down with her, talk about who will be the right match. We go through the matching list and then select the mentor and mentee. Next slide, please. Then we do have some contact notes on the parent buddy and sort of keep updating that as they are meeting and doing their process. Next slide, please. So as I said, initially we had our family advisory board members, 6 parents volunteered. They already had 2 years or more, their babies. And then we paired some of the first mentor and mentee pair was matched in April 2099. So we started the process in March. When we talked about how to support the mentors, these mentors are supporting mentees, but the mentors need support also. That is where the thought about a Slack community came. That was actually for the El Camino specific Slack community to support the mentors. At the same time, both Dr. Balasundaram and I were available to the mentors 24/7 if they need some support and some crises happen, or if they identify a mentee who needs psychological evaluation or support, we will go on doing that. And then we trained more second round, but then came the pandemic. We couldn't do more training. So we have done one more virtual training, but we are going to go back to doing in-person training. And what we do is all parents take 2 hours of online training and then come for in-person, and 1 hour is a role play. So the parents become mentor and mentee and do the role play. Next slide, please. So program evaluation is very important. That way you can keep processing the program well and do the right thing. So the program evaluation forms were developed and given to all the mentors and mentees. Both have to evaluate the program. Next slide, please. And so these are some of the comments. You can see how people are agreeing the parent buddy system is the best emotional support they have got. And it is very important to know that, because as staff and healthcare providers, we are always updating families and we think we are doing the great job. But end of the day, it is nothing like talking to another parent, because we all come as healthcare providers. This is what they do every day. So that's kind of the important thing to remember. The support from other families are important. Support from veterans' parents are important. Next slide, please. More information on the evaluation. Next slide, please. Okay, next slide, please. So these are some of the comments that was written on the evaluation form. And you can see what we heard already and what I'm saying is what they are saying needs to be structured as a friendship and long-lasting friendship, like anything. Gives experienced NICU parents a way to help others feel supported. And one of the things I think we forget that when they become mentors, they also are healing what they went through. The supporting the mentees actually help. And we have more volunteers to become mentors because they received the service. So it's important to set up and difficult at the beginning, but you will see it will grow much faster. Next slide, please. So this is one of the mentor and mentee in our reunion. We also recognize our mentors as FCC Star of the Month. Little token for what they have done. We are working on doing more mentors. And I think one other thing I was going to say, which again, we are all learning. Every 5 years, you want to move mentors out of that veteran parents into next level of help, because I think the current situation is what will help, and we want to do that. Now to Michelle to finish the rest of the support work.
Thank you, Dr. Sivakumar. Hi, everyone. I'm Michelle Wrench. I've been a NICU nurse for 17 years. I'm the mother of 3 NICU children. Throughout my experiences as a nurse and a mother, I've become passionate about providing and improving family-centered care. Today, I'm going to share with you some of the ways that we offer support to our NICU families at El Camino Hospital. Next slide, please. As we know, peer support is a very effective way to relieve stress and enhance coping for NICU's families. I'm going to talk first about our Slack community platform. Our Slack site is a platform that was created by a former NICU parent specifically for our current and former NICU families as a way to communicate, provide support to one another, and to create a sense of community that's accessible from anywhere. We offer access to our Slack community to all of our NICU families by invitation from the Family-Centered Care Chair. Parents use the platform to share their NICU story. It's a place where they can share photos of their babies in a peer-supported setting, and they often ask questions pertaining to life after a NICU discharge, pediatrician recommendations. Some people ask for recommendations on baby equipment like strollers, car seats, things like that, what worked well for other NICU parents. And we currently have 160 members, including 2 NICU physicians, Dr. Sivakumar, Dr. Balasandram, and myself, to help provide additional support when it's needed. Next slide, please. The Parent Exchange Committee that we have in our unit is made up of 2 NICU nurses and 1 neonatologist. My colleague, Tammy Lee, has been providing NICU parent support for over 20 years. Dr. Malathi Balasandram, who is our Family-Centered Care Chair, and myself, a NICU nurse and parent to those are my 3 NICU daughters, Elin, Misha, and Vivian. Next slide, please. Our parent exchange meetings are held monthly. Sorry, this slide looks a little bit different. Our parent exchange meetings are held monthly, where we offer safe and open environment for parents to express needs and concerns. They can ask questions and share about their NICU experience to one another. It gives them an opportunity for parents to connect to each other and to create a sense of community within the NICU. A former NICU parent is always in attendance, whether it be myself or another El Camino Hospital NICU parent who is there to offer additional support for NICU parenting advice and emotional support. We use this safe space to remind parents that they are a critical part of their infant's care team, as well as to empower them to be their child's advocate. Next slide, please. During our parent exchange, we discuss the importance of self-care very regularly. It's a place where we answer frequently asked questions like, what's the best way to find a pediatrician for my baby? Giving them advice on how to navigate the outpatient follow-ups after discharge, discussing vaccination and how to keep their babies healthy, and what life will be like after NICU discharge and preparing them for discharge. We provide resources for additional support, and we also involve leadership to address any parental concerns. We always ask the parents if there's any current concerns that they'd like to bring up, and we hope to offer them a solution in real time while they're in the NICU, and not just for future NICU parents. We started the meetings in person in our conference room, and during the pandemic, we moved to our Tranquility Garden so we could be outdoor, socially distanced. Within the last 6 months, we've moved our meetings to be completely virtual. We have found that doing our meetings virtual work really well for NICU parents, whether they're coming to and from the NICU to visit, maybe a break in their workday. Some parents are back to work and traveling internationally, and they can still join our parent exchange. Mothers who are pumping or parents who are holding their baby skin to skin can still contribute and feel supported by doing it virtually. This is the end of our presentation today. I hope this has been really helpful for many of you and gives you some new ideas on providing family-centered care in your unit. I want to thank all of you for your interest and desire for change in the way that we provide and support and give compassionate care to our patients and their families. I'm now going to pass it on to pass your attention to Keira and Meegan. Thank you both for working and helping families during their NICU journey.
And thank you so much for having us. Meegan and I are really excited to be able to have this opportunity to talk about national peer support organizations and maybe even demystify them a little bit. I know we are running short on time, so we will do our best. But we're going to identify key characteristics of national peer support organizations, and also, most importantly, reflect on opportunities to partner with national peer support organizations. Meegan and I are both leaders of the NICU Parent Network and Graham's Foundation. Graham's Foundation is actually one of our founding members. We started off in 2012 with 5 organizations. The organizations with the star by them are part of the founding members. They were part of the leadership team that helped us kind of build the foundation for what we are now, which is 42 community-based NICU support organizations, small businesses, and advocates across the US. We also have a few global global organizations in the UK and Israel. And we currently are the only US-based collective of community-based NICU support organizations. The previous speakers have already touched on this, so I won't spend too much time on this, but as Dr. Hynan said, peer-to-peer support is a proven mental health intervention, and it is supported by SAMHSA, the Institute for Patient and Family Centered Care, National Perinatal Association, and of course, the American Academy of Pediatrics. And it just, again, speaks to that peer support is intentional, it's personalized, it's real life, it's real time, and it can only come from someone who has that lived experience. The NICU Parent Network feels very strongly about the provision of an equitable access to peer-to-peer support in the NICU. We wrote a position paper, and we state that we advocate for the establishment and funding of peer-to-peer support services and peer mentoring programs in all NICUs, because we know, and we have decades of medical literature and research to tell us, that when we appropriately address the mental health needs of parents, we see better outcomes for infants, and we see lower rates of perinatal mood and anxiety disorders. If you want to scan that QR code, you can download our full paper on the peer-to-peer support services and why we believe so strongly that it is a key component of supporting family-centered care in the NICU. So just looking at what this first objective is, to identify some key characteristics of a national peer support organization. One of the key differentiators that we make with our members as a professional organization is that they are all running organizations or small businesses. So that's what Meegan and I are going to be focusing on today. We felt it was important to kind of make this distinction, because when you're running an organization, you're running a business, and there is that, that level of commitment and professionalism, legal compliance that has to be present so that you don't lose your 501c3 designation or your certificate of good standing. And we also just want to state that, and you'll see in our next slides, that national support organizations can be a really wonderful added resource to local support groups and support organizations. It's all about, creating that holistic support system for the families. So just some of the things that you'll see in a national parent-led organization that you would see in any of the members of our network are that they are 501c3s or small businesses. They're community-based, although they may contract with hospitals. They'll have a paid or volunteer leader, their paid or volunteer staff. All of our specific members are parent-founded and parent-led. And all of the support services are provided by trained veteran NICU and bereaved parents. The other thing that just about all of our member organizations do is not only do they provide services, support, and resources in antepartum or in the NICU, but also well past NICU discharge. So I'm going to have Meegan now talk a little bit more about some of these characteristics.
Hi, so like Keira was saying, the national organizations provide services anywhere, regardless of the location of where the parents are, the time, no matter where they are. An example of that with Graham's Foundation is we will service any parent no matter where they are in the US. But we also will do outside of the US. We've recently had an American mother who was vacationing in Saudi Arabia and had a preemie and had no idea what to do. So she reached out to a friend who said, hey, I'll connect you with a mentor at Graham's. And we were able to connect with her via messaging services and support her through her, issues at her NICU stay while she was in Saudi Arabia. So that's not completely normal for us, but we will do it. We will always help any parent that we're, able to. And many national organizations will partner with other local support organizations to ensure that there's a holistic support network for the whole family. The goal for any support organization is that the parent gets not that the parent gets services only from their specific organization. Our goal is that every parent gets the individualized support, education, and resources they need. There is more than enough need, as we all know, and not every organization will be the right fit for every parent. Being able to draw on trusted national organizations or a network of organizations is a huge bonus for any local resource available. Our organizations stand in that gap if a local resource isn't available, is inconsistent, or maybe you can't find an appropriate match for your family, even if you do have your own mentor program or support.
When Meegan and I were preparing for this, it actually just kind of dawned on me during my own NICU stay. I had a not atypical, of course, what NICU stay is typical, but I did have triplets at 25 weeks, and one of them struggled a great deal more than the other two. Our hospital was wonderful. Our primary nurse was NIDCAP certified. We really had so many resources in the hospital for us. And there was a woman who led the support group, but she herself had a singleton who was in the PICU who died of a childhood illness, where, I was sitting here in the NICU with 3 very tiny and very sick babies. But what she was able to do was connect me with a national organization called Mothers of Super Twins. And that was where I found my individualized support, because they were able to pull from their national network of mothers of high order multiple. So it was all mothers of, triplets, quads, quints, and sextuplets. And they were able to match me with a mentor who was trained, who had 3 boys. I had 3 girls, but one of her kids struggled a great deal more than the other 2. And so there were so many parallels. It also became a part of, or I became a part of, they had a same age group for high order multiples. So if your kids were born in the second half of 2006, as mine were, we were kind of like filtered into this group. And still, we have gone through divorces, illnesses, deaths, childhood illnesses, deaths of some of our children. We're, looking at all of our kids are now turning 16, and we're sending them off on the road. But, it's just that strength of that individualized support. And so it was, I was really able to kind of build this support system around me with this combination of what the local hospital group provided, as well as what this national group was able to provide for me. So a lot of these organizations have a very large list of services. They may provide some generally not all, but this is a list of which kind of shows you the access to additional resources that maybe your hospital doesn't have the capacity to develop. We also, who wants to reinvent the wheel? So if you know that there are trusted organizations out there with educational resources that you can tap into for your families in the local setting, podcasts, apps. We know that through our network of members, there are virtual support groups based on the special needs of the children post NICU. There are groups and peer mentors specifically for dads, for families of color, and also, really focusing as well on extending those services past the NICU. So when you're transitioning home and then you go into that school age, and if you have a NICU kid, a lot of times, whether it's preterm or full term or late preterm, those issues follow you for a long time. We're in high school, sophomores, and they're still following us. But being able to have this large network of resources to pull from, I think can be just a wonderful way to further enhance what you're already doing at the local level for your families. And I do want to point out, as has been mentioned by every speaker so far, is the importance of that peer-to-peer support. And that's why I have those bolded. And as was talked about, it is critical that those mentors are screened and trained. Initially, in my own personal experience, the woman who ran the hospital support group set me up with another triplet mom from that hospital. But now, knowing what I know now, thinking back, she was not trained at all in peer support. And it wasn't nearly as organized as was shared with what they're doing at El Camino Health. And that's just so critical to have that infrastructure built in, to have that screening, to have that training, to be able to support your mentors as well. And I know, Meegan, you have spent a lot of time through Graham's Foundation and with Parent to Parent USA, related to this. So I would love for you to share a little bit more, because that is definitely your area of expertise.
Thank you. So my job at Graham's is the Premier Parent Mentor Program. So I am in charge of recruiting, screening, training, ongoing training, everything to do with the mentors, including the matches. And as Keira said, I cannot stress enough training, screening, making sure that these parents who are also trauma survivors are getting the support that they need, and they are capable of supporting another parent. I know that in the last speakers did bring a lot of this up, so I won't go over the same things, but I will talk a little bit about how at Graham's Foundation we do support both our mentors and our mentees. We are national, so our parents are not meeting in person. Our parents are text messaging, they are having phone calls, emails, or using messaging services. We don't meet face to face. We are purely virtual. We always were virtual. And so we were set up, really prepared for the pandemic. Another thing that is super important is ongoing training. Just doing it once at the start is not enough. We meet monthly. We make sure that we have ongoing training. We could have different topics every month. And so I'm getting the 2-minute warning, so I'm going to wrap this up. But the one thing that I really do want to stress is trauma-informed language. I think that there needs to be a very big focus on everybody that works in a NICU, not just the peer supporters, the doctors, the nurses, everybody, on making sure that they are using that trauma-informed language. Language really matters. And when you are supporting a parent in the NICU, that language is so important on how you say it. One example before, I saw that someone brought up about chaplains. Some parents might think, a chaplain? Oh my God, is my baby dying? So just the way we present things, the way we use words is really, really important. So that ongoing training is something that I think is really important. Something else that is really important in my program and how we run our mentors is the power of saying no. I understand that our mentors themselves have their own preemies at home that may be, older, starting school, dealing with IEPs, dealing with other issues. that they need to always be in the right space to be able to take onto a match, and that it's okay to say no. Something we could probably all learn in our lives, but that it's okay to say no, and you don't have to say yes to every match. There's always someone else that can take on that match. I'll hand it back to you quickly, Keira, since we're running out of time.
Okay. All right.
Get faster and faster as we talk.
Let's see what we can do. So, we want to talk really, really quickly about the, how do you partner with community-based national organizations? And there are a lot of different ways that this can look. Some of the partnership models include a business associate, just like you would for any other vendor. One of the questions that we're often asked is, well, how do you know if these community-based organizations or national organizations are legitimate? And then I kind of turn around and say, well, how do you know your billing company is legitimate? How do you know your transcription service is legitimate? It's because you vet them. And so my last two slides, which I believe these slides are going to be made available, has some key questions to ask to help you in that vetting process. But a business associate, what we saw with the COVID pandemic was that even organizations who have been partnering with hospitals, whether it's to do their peer-to-peer support or in other ways like bringing care packages or doing educational resources, because they were through volunteer services and the hospital shut down all volunteer services, that meant when families needed it most, the family support services were cut off, except for our members who had a contract in place with the hospital as a business associate, because they were then designated as essential. And so that's really key. And even though it sounds like, oh, that's a lot more, a lot of steps to go through, it really is key in making sure that there's not going to be an interruption in the services that can be provided to your families. As far as funding, there are different hospital budgets that could potentially come through. Some organizations will ask for a charitable donation to help support what they're going to do in your hospital. Others do have a fee for their services, depending on the breadth and scope of the work. And some are, completely volunteer-based. So these last questions just have to do with, the operations. And it's really just like any other time that you would vet a service or a company, understanding the processes and programs they have in place. How do they handle concerns if a mental health professional is needed? Asking for references, and then also asking the organization, what do they need for a successful relationship or partnership? And Meegan, this is our last slide, and I'm sorry we're a couple minutes over, but you want to run through these just quickly?
Yeah, so we'll go through this quickly, but like I said, mentors must be trained. There has to be a screening process, and if any of you or your hospital wants to reach out and ask me what mine are, I'm always upfront. I'll always tell you exactly what we do, and any organization that you're thinking of partnering with or doing that should be able to tell you that. That those who interact one-on-one with current NICU families have some distance from their own experience, to not re-traumatize current families. Every organization has different rules on this, but a bare minimum of 1 year out from the NICU is generally our rule of thumb. And then there's also policies around confidentiality, liabilities, and boundaries with families. At Graham's, we set our boundaries as they can be friends with them on social media if they want to, but they're not going to start them a GoFundMe and give them money and things like that. Facebook groups and other online communities should always be moderated by a trained peer support specialist. I'm sure a lot of you have seen groups where people are acting like doctors and giving out medical advice. There should always be trained peer support on these groups to help moderate that. And then HIPAA and confidentiality should always be handled in a contract with the organization to ensure compliance with hospital regulations. Obviously, that's different for every group. For us at Graham's, because the parents are sending us a request for a mentor individually, we don't have the HIPAA coming in with giving any information out because they are freely giving us their own information. But again, if you have a contract with a hospital, that could be different. So those, things to take into consideration if you are starting your own program, partnering with a program. Yeah.
So that's all we have, and we're happy to answer any questions.
This is great. I think that's such a wonderful list of resources and questions to ask for folks. So we have just a couple of minutes to ask a few questions of all four. I'm adding some spotlights, hopefully. So I have one question that I'll start with, and we'll see how much time we have. In terms of identifying potential mentors, how do you do that? What makes a good mentor? What are some things that maybe you can't really train someone in a particular personality? What are things that you're looking for with potential mentors?
I can start. So part of our process is an interview process where they have to tell us their story. And straight off the bat, you can tell if a parent is ready or not. So I often tell parents, I'm sorry, I just don't think you're at the point in your journey yet where you are able to support another family. Mentees, people that have been mentored, make the best mentors because they know the process, they understand. If you're in a hospital setting, parents that were very, involved in the NICU, asking all the good questions and that you had good relationships are always great places to start. But for us, definitely, even if you think they're a good parent, still get them to tell them a story. You'll know if they're ready.
Anyone else want to jump in on that one?
One more thing to add. The other thing that I do in my interview process is I tell them my story. Because if they can't listen to me telling my story without interrupting me, without talking over me, without making their trauma more than mine, it was different. They're also not ready. So that's a really big part of, they just think I'm telling them my story, so they get to know it. But it's probably one of the biggest parts of my interview process.
Yeah, that's a great sort of test. Yeah.
Even at the local level, we do the same. We will ask them to tell their story and how their baby's doing now and where their emotion stays when they are telling the stories. That really reveals us whether they are ready. And if they are starting to cry and they are having some emotions, then we know they are not ready. And one of the 24-week mother who wanted to join, she couldn't do it for 4 years. Took her that time. So it varies the time they can come as mentors varies.
That's great. I think in our last few minutes, I'm going to pass it over to Colby. I put a link in the chat. If we didn't answer your question, please add it there. And we will work to get to it on that Padlet forum.
Thank you all for speaking today. I think we've had some really amazing information and some really incredible personal stories. So we do appreciate you opening up to us as well. We will have our next webinar on January 12th. It's at the same time, so 11 a.m. Pacific time, 2 p.m. Eastern time. And we'll be focusing on how to do family integrated developmental care and then some variation in family-centered care metrics across California. And here's our QR code for our evaluation. Please do fill out the evaluation if you have time. We do look at all of the comments that you put in the hopes that we can continue to improve with all of our offerings. And happy holidays to everyone, since we won't see you until the next calendar year. Thank you so much.
Thank you, everyone.